and try not to fall asleep. This is like the worst time to give a talk because everybody's like snoozing. Oh, thank you. So I'll try and say something in the middle there to keep you awake, or at least astonish you in some way. Whoops, I guess we better, yeah. There we go. Good. Well, this afternoon we're going to chat, or I'm going to chat a little bit about other pharmacological approaches that are certainly sort of coming to fruition in the literature and, have potential to get to the clinical bedside in the next few years. But hopefully at the end I'm going to raise a few issues about what maybe we should be looking at from the perspective of which children we're treating, when we're treating them, and what it is that we should be using. So hopefully by now you're recognizing a theme, at least in my perspective, from my talks, that really that broad spectrum of injury to the newborn brain is not just something that happens over a few weeks, but it's something that happens, as Nick has pointed out, to a rapidly developing nervous system that is sensitive to its environment, both internally and externally, and that we have to look at as an individual so that we're using the right treatment and so that we're not throwing the baby out with the bathwater. In other words, if a treatment doesn't work in a large group of individuals, it doesn't mean that it won't work in a specific group of individuals. And so we have to be very cautious and careful about how we interpret our data. So as a reminder of that, this is a recurrent slide because I like it so much. Right now, a lot of the things that are in the literature, including hypothermia, that I'll talk a little bit more about tomorrow, are really based predominantly on term newborns after the time that they're born, obviously, and after the time that they've received injury. And if you remember this slide, the vast majority of the children who actually are injured in the premature period of time, antenatally, and either still in the womb or after the time that they're born over a series of days and weeks while they're being cared for in the nursery. So what's available out there now, including hypothermia, is really for that small percentage, 10 to 15% or so, that are already born and that we would consider to be, rescue therapy. This group of individuals that does approach the neonatal stroke to some extent, although hypothermia hasn't gone in that direction yet. The kids who have a hypoxic ischemic insult, and it's largely rescue therapy that we're looking at in only about 10 to 15% of individuals, and I'll talk about that a little bit more tomorrow. Rehabilitation is certainly coming onto the scene, and I'm not going to really deal with that because that's a discussion in its own right, but an important one because certainly with things like constraint-induced therapy, transcranial magnetic stimulation, and other advances that have been made and are being made in the rehabilitation field, we are seeing some real good progress in that group of individuals. What I'm going to talk about today is a little bit of prevention and to some extent a bit of rescue, but I want to point out that we're really talking about mostly individuals who are in that small group of 10%. And we have to realize, too, that now in the world of mild hypothermia, where to greater or lesser degrees it's being accepted as a standard of care, virtually everything that we talk about has to be inclusive of this. And most of the literature that's coming out now, you'll probably recognize, is not inclusive of hypothermia. So studies that have been done are in individual drugs. There is some literature certainly coming out on combination therapies, and I'll touch on that both later today and tomorrow. But most of what's coming out is individual therapies in the absence of hypothermia. And so simply adopting some of these things in a baby who has been cooled, again, is something that we need to consider and think of before we simply adopt it because a paper really kind of looked good. or sounds good, or it's only happened in an animal model. So again, I'll point out some really nice review papers that have really come out in the last, mostly in the last year, and some of them just in the last few months or so, and are from Nicola Robertson, which asks which neuroprotective agents are ready for bench to bedside translation. This is an excellent paper from a group of really experts throughout the world who have analyzed a number of drugs that may be ready for bedside translation. And I don't agree with all of it, but but nonetheless, it's an excellent summary, and it's an excellent systematic review of the literature that's out there. Linda's smiling at me, and I don't know if that's a good smile or not. There's a paper by the Italian group who have done something similar and done a very nice review of pharmacologic and therapeutic approaches, and they largely agree with some of the suggestions by the North American and European group. And then Michael Johnson has also written a nice review around the same thing. So if you're wanting to sort of get more detail about some of the studies that have been done, these are three really good reviews to have a look at. And if you fall asleep after this, but write down these, then you're good. You're good to go. This is a couple of tables that were taken from Nicola Robertson's paper from JPEDS, and you can see here that they've listed potential antenatal neuroprotective strategies. So these are medications that they feel may be beneficial to actually be given to the mother during pregnancy. So this is an approach I think that's very important and really hasn't been looked at to any great extent. And to be quite honest, how they came to that analysis is a bit odd because none of these, or the vast majority of these drugs have not at all been tested antenatally in animals or otherwise. There are a couple studies, and I'll show you some work that we've done in our lab, but virtually none of these have been tested antenatally, except to say that they've been, some of them have been approved by the FDA, the Federal Drug Administration in the United States, for use in pregnancy, but certainly not all of them have. And I'll talk about the ones that have been approved by the FDA because those are the more likely ones to reach any kind of clinical trial in the next couple of years. So it was intriguing to me that they said antenatal because really, I don't know how they came to that conclusion when they haven't been used. And then there are a group of potential postnatal medications, the rescue therapies, that they've also suggested. And if you look closely at these two tables, there's really a lot of overlap. Many of the drugs that they're recognizing as being good for antenatal are also good for postnatal. They've simply ordered them in a slightly different prioritization fashion. So I'm going to jump right into some of those medications. And the first is tetrahydrobiopterin, which is really kind of a vitamin and an enzyme inducer that's freely present within the brain. It increases in time over gestational age. These are measurements in newborn rabbits, actually. From E22 to E32, and they're most highly prevalent within the deep gray matter regions of the thalamus. And this group by Sid Tan in, I think, Oregon, if I remember correctly, is along actually with Alistair Gunn, are undertaking a number of studies where they're looking at various medications in their rabbit model of cerebral palsy and injecting their animals with various medications. And in this group of studies, they looked at giving hydrotetrabiopterin in their animals. And what you can see on the left-hand side, I'm going to just step over here. Oops, I can't see. What you can see there, whoa. On the left-hand side is the vehicle in the clear bars and the BH4 in the gray bars, and they're just looking at evidence of spasticity with muscle tone or dystonia and a locomotor score, all behavior scores on a writing reflex that are done very early in the life of a rabbit or a rat, depending on which animal they're using. And they showed significant improvement in both of those, in all four of those scores, with the use of tetrahydrobiopterin. And this is one of the medications that they suggested would be safe for the use antenatally because it's present in the fetal brain. It's basically a cofactor that can be given. It crosses the placenta, and obviously in this animal model is effective. And I kind of like this approach because it is one where we know the cofactor is already present in the fetus, and really what you're doing is enhancing, presumably, their endogenous activity so that it can be effective in neuroprotection. Pierre Gresson's group has looked at melatonin fairly extensively over the last number of years, and it's felt to be another medication that's approved by the FDA. It's used in children already, as many of you may know, for sleep disorders and often to enhance sleep, particularly in kids who have cerebral palsy or developmental difficulties. It too crosses the placenta and is FDA approved for use in pregnancy, and so it has, again, a wide potential for use as a medication for the treatment of asphyxia. And again, this is what they did in this group is that they use he uses a neurotoxin, and he injects it into a mouse brain, and it causes a small lesion, in this case along the corpus callosum and in the cortex. This dark brown area here is the corpus callosum. Above it is the cortical region. You can see the cyst that occurs, and following the use of melatonin, and this was actually after the injury, they got improvement in recovery in the white matter, and when measured specifically in terms of thickness, the cortical plate, there was not much difference, but the white matter, there was significant improvement. And that's shown here as well. These are controls, and then the medication is used on that side. So melatonin is another agent that can be used. And then in the last actually couple of weeks, there was a publication by, I believe this is a Japanese group, using melatonin antenatally. So this group used a model of what we call bilateral uterine artery ligation, and I'll show that to you a bit later because that's what we're using in our lab. And what it induces is basically placental insufficiency for a period of time, depending on how long before delivery you induce the ligation. And it's, in my opinion, a nice model of antenatal injury, and one of the models that certainly provokes brain injury in the newborn. And what you can see here is this is the hippocampus and a control, and it looks all very nice. After the intrauterine artery ligation, you see injury, and once they had given melatonin, there's improvement in histologically, or actually it's not really protection. What they're doing here is preventing the injury from occurring in the first place, because it's given prior to the onset of the ongoing injury antenatally. So it's a very nice kind of model. Here they've looked at mitochondria, and again you can see a real disruption of the mitochondria with the model, and an improvement or prevention of that disruption in the majority of mitochondria with melatonin. And in this case, they've measured the reactive oxygen species using T-bar and have showed an improvement in the reduction of reaction oxygen species as well. So this has been a nice model. There certainly can be a bit of criticism around how they did the study once you read it a little bit more thoroughly, but they've got some good preclinical evidence here that antenatal melatonin may be effective under these circumstances. So all of you have heard a lot about erythropoietin because this is what everybody's been looking at, both from a preclinical perspective as an isolated entity and as a post-injury perspective as well. And certainly there have been a number of studies, a huge number of studies actually, both in the premature animal model and in the term animal model, using erythropoietin as a neuroprotective agent. Again, it's approved by the FDA for use. It's been used by a number of neonatal units, although we don't use it in Canada, I don't think very much, but it's been used by a number as a hematopoietic stimulant. It's approved, it crosses the placenta, and it has a wide variety of activity, including all the way from neurogenesis to an antioxidant agent to an anti-inflammatory agent. So it has very broad spectrum aspects of things. And so this is a study where they looked at erythropoietin in the Vannucci model of stroke, which is the 7-day-old model, and they just looked at multiple doses at various times and showed an improvement in behavior in this group by about 30% of infarct size and an improvement of 40% in neurobehavioral outcome. So from a preclinical perspective, that's really been shown to be very effective. This is another study looking also in vitro at cell viability with kainate as a neurotoxin, not as a seizure inducer, but as a neurotoxin causing cell death, and with serum or EPO, and again showing an improvement in cell viability either with kainate and kainate and EPO or alone, and showing that improvement. And here with Kim, they've used the Vannucci model, and again showing improvement recently in the hypoxia ischemia model in terms of brain injury. So there's a huge amount of preclinical data suggesting that erythropoietin is effective in isolation or using it alone, both in the preterm and in the term infant. And there are some early preclinical trials that are suggesting that it's safe to use in the newborn. And there have been a couple of studies that I won't refer to here, but will tomorrow when I talk about hypothermia, looking at hypothermia in combination with EPO. And, well, the bottom line is those are maybe not as impressive as they are with EPO alone. Allopurinol is another medication that's been used clinically quite a bit. There are a couple of European studies that have come out. And what I did was just summarize here some of the systematic reviews that have been done in the last few years to look at the effectiveness of allopurinol in some of the clinical studies that have been done. And there have been about 3, one from, I think, the Holland group as well, is that not correct? And then others, mostly within Europe. And if you look over here, basically what you see is that if you go left to this line is supposed to be in favor of allopurinol, right to the line is in favor of control, and in the middle is really no difference. So if we look at infants with severe encephalopathy, allopurinol is really a bit of a fence sitter. It really did not seem to have significant improvement in terms of overall outcome. And remember, this is a systematic review, so it's accumulated data from these 2 or 3 clinical trials that have been done. If they looked at allopurinol versus control in terms of seizures during the neonatal period, again, a bit of a fence sitter. The last or the earliest study done in Holland in 1998 was probably the best results, but a very wide spectrum of in terms of standard deviation. And so, again, allopurinol right now, at least from a clinical perspective, it's not sure whether or not it's really going to be of any benefit. Where they did a sub-analysis of the RCTs and looked at death and severe adverse outcome, in other words, separated out death from severe developmental disability as a sub-analysis, that's where they did start to see a little bit of significance. So when they looked at the various studies, and this is just recently by a group in 2012, they separated out death. And in their systematic analysis, and again, this is in all 3 studies, they found a bit of an improvement, a significant improvement in terms of the allopurinol versus controls in terms of the overall death. And they found a similar improvement in severe adverse outcome. So basically, again, this is where one can get tied up in throwing some of the baby out with the bathwater if you group all of the individuals and then find no significance. So in the previous systematic reviews that I referred to, they looked at all comers, basically mild, moderate, and severe outcomes, and found that allopurinol was kind of sitting on the fence. But when they did a sub-analysis of those and looked at death and severe disability separate from the moderate and mild outcomes, they actually did find improvement. Now, this systematic review, in my opinion, is actually pretty important because the group of individuals who are really not getting any benefit, at least the term individual and HIEs who are not getting any benefit or not much benefit from hypothermia, is actually this group, the severe outcomes. So there's some, I think, theme here or underlying theme that may suggest that the combination of hypothermia and allopurinol may in fact not be a bad choice in terms of moving forward to preclinical trials in animals and then possibly a clinical trial, because that would seem to be a very complementary approach to things if in fact this turns out to be true. So those are some of the studies on allopurinol. NAC, or N-acetylcysteine, that's been looked at by a group in the United States led by Dr. Singh, and they've looked at NAC for quite a number of years, and it too has a broad spectrum of application, as do, frankly, most of these medications, which is a little bit scary in some ways. But all of these medications tend to have a broad application to being anti-inflammatories, antioxidants. Some of them show some neurogenesis capacity, and in some ways that's probably good because there's likely not going to be a silver bullet that fixes everything. So they looked at this unilateral ligation model that's so prevalent, and this is in their early studies, and this is pre-treatment, so they gave the medication beforehand, before the injury, and found that indeed, as opposed to this large infarct that we see in these neonatal rats, NAC seemed to diminish or prevent that from occurring in a significant fashion. And then when they scored the animals and looked at regional variation, not surprisingly, that turned out to be the case. When they looked at post-treatment, or the Mallard group actually looked at post-treatment with NAC as opposed to pre-treatment, they still did find an improvement in the overall area of infarction, but it wasn't really quite as dramatic as what you're seeing here. And many of the medications seem to go along those lines. If you give the medication beforehand, it seems to be really quite wonderful. If you give it afterwards, after the incident has occurred, it's not always as wonderful. We can have a whole discussion about whether or not anything in animals is relevant to the human, but that's another symposium, actually. But we can certainly have that talk. And again, very recently, in the last couple of weeks, with the help of computers, we can look at things like up to the minute of the talk. So this came out actually just in e-form. They gave prenatal NAC to an LPS model, lipopolysaccharide model or inflammatory model, which is slightly different than the earlier ones with the unilateral ligation. And again, they just looked at the inflammatory response. So they didn't look at any pathology, they didn't look at any behavior, they just looked at whether or not NAC under these circumstances, using bilateral uterine artery ligation model, prevented the inflammatory response from occurring. And really, they only looked at one time point. They did the bilateral ligation, gave the LPS prior to delivery, gave the NAC, and then sacrificed the animals on day one. So this would be a real sketchy kind of paper, but it's the only one that has come out. And what you see is certainly with IL-6 and IL-10, both pro-inflammatory cytokines. You can see with LPS and NAC, either alone afterwards, alone or on two occasions, really reduced the inflammatory response. And when they looked in the so this is in the brain of the fetal rat pups, this is in the amniotic fluid, and really very similar alterations, suggesting that it has both a maternal effect, in other words, an effect on reducing the systemic maternal inflammatory response, and a fetal effect in terms of reducing the brain inflammatory response. And then this is that same group that recently looked at NAC and HIE, again looking at the degree of injury. This is without NAC, this is with NAC, pretty dramatic improvement. This is pretreatment in an LPS model. Again, very dramatic improvement in the inflammatory model. Here again, this is just a graphical analysis of the degree of injury that was prevented in that slide. So both from an inflammatory perspective and from a hypoxia ischemia or a stroke perspective, NAC seems to be very potent as a preventive agent and as a protective agent, and again is somewhat safe, is a bit of an endogenous protein that's available. It crosses the placenta and can be utilized, or certainly has a good preclinical evidence for utilization. So there's all kinds of things, and probably by now, even though I'm an animal researcher, I'm also a skeptic. And so I think we have to sort of really ask the questions, because in the lab, and I don't mean to detract from animal research, because that would be shooting myself in the head, but in the lab we recognize that, you know, a lot of things work in the lab. A lot of things protect animals from the brain damage that I've been showing you. And certainly when we look at the human being, both in the adult stroke world, where there have been a lot of studies done, and I'll show you, and in the newborn, it doesn't always translate so nicely. If it did, none of us would probably have a job. We could all go home. But it doesn't really do that. And in the newborn in particular, and this was pointed out by Roberta earlier, we have all kinds of glutamate blockers, blockers of programmed cell death, anti-inflammatories, antioxidants, you name it, we can make it, and we can give it to animals. But there's a problem in the newborn, and that is that all of these, glutamic acid, programmed cell death, inflammation, even free radical production, are part of the normal physiologic cycle of the development of the brain. So if we block these things exogenously by pharmaceuticals, we have to be very careful. And this is where I think a big question about risk versus benefit comes into play. And again, sort of I throw that out as something that really we need to be highly cognizant of. And the other reason I throw that out is that these are clinical trials. And this is actually a fairly old slide from early 2000s, so these numbers are going dramatically up. But at that time, these are adult stroke trials. 178 trials in adult strokes of pharmaceutical agents that worked in animals, 50 of them in this circumstance. So I don't know if any of you guys know about clinical trials, but an adult stroke clinical trial, each one, couple $1 million easy, without batting an eye. So we're talking about several $1 billion here. None of them worked in humans. None. Not one. Which is amazing. And yet, surprisingly, we're still doing this. So we're talking about billions of dollars, all funded by the pharmaceutical companies, thank you very much, but are really ineffective. So my point is that there's a missing link here. And my feeling is that part of the missing link is two things. One is the idea behind animal models is that we eliminate all the variables except the one we want to look at. But we all know that life is not like that. If we could all eliminate the variables that we don't like about life, we'd all have a perfect life. But we can't because, things happen. It rains, it snows, you have an argument with your wife in the morning, things happen. And that, as Nick has pointed out, have an effect on us in some way, stressful or otherwise. So the animal model, while it's a good preclinical choice, is not entirely reflecting the human condition so much. And the other aspect is that most of the preclinical trials at this point, and we are getting better at this, have not looked at repetitive therapies. They've not looked at multiple dosing for the most part. They've not looked at long-term outcomes, long-term pathology, or long-term behavior, because things change over life, things change over time. So we know from actually the hypothermia trials that if we gave brief periods of hypothermia, that seemed to work in the first couple of weeks, but if we looked at the animals later on, it actually didn't work at all because there was some transiency to the effect. And again, I'll talk about that a bit more. But so these things have not been congruent with what really happens in life. And I'm sure there are other genetic and epigenetic influences that we're not taking into account in the human, or in the animal that is occurring in the human. And the other aspect is that we've tended to be lumpers. So something that works in an animal, like a Wistar rat of X age and under X conditions, we've adapted to, all strokes in adults. Well, not all strokes in adults are the same. And my suspicion is that if we apply it to a specific circumstance that more mimics the animal model, or vice versa, we would in fact probably find some benefit from these drugs. But we've been lumpers. We like, pharmaceutical companies especially, they want to have a drug, they want it to work for the whole world right away and make a lot of money. But it ain't going to happen. So we need to be smarter about that. Anyway, that was a bit of a tirade, sorry. Anyway, so we need to recognize that all of these things are involved in the physiologic growth of the newborn brain. And as was pointed out earlier, what we see is if we interrupt the NMDA receptor in a normal brain, and this is a long-term study done and published in Science in 1999, lo and behold, it causes a lot of apoptosis in a normal brain. So if we don't know if the baby's been injured antenatally or postnatally, again, as was pointed out, probably not a good idea to treat. Better idea to think about it, see what the real underlying diagnosis is, and then think about the treatment that we're looking at. This is just a bit of work that we did in our lab with caffeine and that we published a little while ago. And so we looked at caffeine and morphine individually and together. because that was being used a lot in our nursery for apnea and apnea prematurity and pain. And this is a normal untouched rat brain in the thalamus region. This is a rat brain on drugs with caffeine, and this is caffeine and morphine. And what we can see in this fluorojade stain is that we have a high incidence or an increased incidence of apoptotic or programmed cell death. And when we characterize that, that occurred in various different regions, in the superior colliculus, in the CA1 region of the brain, and in the whole brain. But surprisingly, the addition of morphine didn't actually make it worse. It was really the caffeine that seemed to increase the cell death. Now, that's not to obviate the value of caffeine in kids or in premature babies who have apnea prematurity. What it's meant to do is say that not all of these medications are benign. And so unless we have a good reason to use them, we need to be careful about that. So I'm just going to move on, I think, to what we're facing as a problem. So we often know that babies get injured when we can't see them. In other words, in utero or during the period of time of prematurity where they're being monitored in the NICU, but we're not entirely sure when the injury is actually happening. We know it is, but we're not entirely sure when it's happening. And it can occur at a time during gestation or soon after delivery, and things that we might do to help the brain may actually have a potential to hurt the brain. So we have to be very thoughtful, especially when we're looking at a maternal-fetal environment, about what we're actually doing and what we're giving to the brain. And so we have to do or develop therapeutic interventions that really span that spectrum of fetus to newborn, but also balance neurotoxicity and normal development in a rapidly progressing and developing immature brain. So it's a daunting and it sounds almost impossible task, but the good news is we're actually making really tremendous progress, I think. Number one, we're recognizing this. This is, years ago we didn't even think about it, to be quite honest. Number two is, we have techniques now like epigenetics that probably will, and Neuro-Imaging and a host of other biomarkers that probably will be able to help us do person-specific or fetal-specific or newborn-specific therapies that will fit into certain categories and may be helpful. Our challenge will be convincing the pharmaceutical companies to take that chance. So this is where I get to be a little bit crazy because I'm old and pretty much say whatever I want. But what we've looked at in our lab is going back to basics. And what I mean by that is looking at some natural health products. And we're doing that because of all the issues I pointed out earlier, and because I feel that pharmaceuticals may not really fit ethically or morally in giving them to mothers unless we can prove that they're truly non-harmful to both. And so if we look at, food, frankly, natural health products that really are endogenous to the system, but as we all know, contain high levels of antioxidants, maybe there's a way that we can look at that. Much the way that folate has worked really for spina bifida as a vitamin supplement during pregnancy and has been adopted, I think, worldwide as one of the prenatal vitamins that are being used. So there's been some work done with certain things. Resveratrol is it's not a natural health product, but it stems from a natural health product and is being used. And here's a nice study published recently, again, in the Rice-Vanucci model of unilateral hypoxia ischemia. This is control. This is microscopically looking at the myelin-genetic region and the corpus callosum in terms of myelin production. And this is after giving resveratrol, virtual prevention of any injury at all. And then looking at some of the behavioral aspects, a real improvement in terms of recovery over time compared to controls this is looking at water maze and memory, so a cognitive approach, and this is looking at rope suspension, so looking at strength or a motor approach, and improvement in all three aspects, pathologically, cognitively, and motorically. So again, strong preclinical evidence for resveratrol as being used. This is work done by David Holtzman. He looked at pomegranate juice, again in the Rice-Finucci model at varying doses. This is using plain water and the percent of brain loss. So obviously very high in the control animal. And when he gave pomegranate juice, best results in the high dose, but really even in the moderate and low dose, he still saw significant improvement in overall outcome. And then when he measured the amount of reactive oxygen species in the control, it was markedly diminished in the treated animals with pomegranate juice. Most recently, there's been other work done with grape seeds and grapeseed extract, and there's actually a company in California that provides a grant on a yearly basis for preclinical work to show the benefit of grape seeds. And again, using the Rice-Finucci model, varying doses of grapeseed extract markedly improved the amount of tissue loss that was seen in the ipsilateral hemisphere at both doses, 25 and 50 milligrams. When they looked at glutathione, there was again an improvement in the production, of grapeseed extract. This is looking at a microscopic score. And then when they looked at prostaglandin production as an indication of inflammation, again, there was marked improvement. So already we have grape seeds, pomegranate juice, and resveratrol that have been very effectively beneficial. So our lab has looked at broccoli sprouts, and in Canada you can buy broccoli sprouts at our neighborhood grocery store. And we've looked at broccoli sprouts for a couple of reasons, not because we don't like pomegranate juice or grape seeds, but because broccoli has actually had a ton of preclinical work and actually has gone through clinical trial in cancer therapy. Why cancer therapy is because it's a phase 2 enzyme inducer. So it basically looks at the endogenous antioxidants within your system, like glutathione peroxidase and glutathione reductase, and it increases those levels. So it's not doing anything abnormal to your system, it's only increasing your endogenous productivity. And why broccoli is because broccoli sprouts, those little sprouts, have between 50 and 100 times more antioxidant capacity than the mature broccoli, for one. So it's good to eat broccoli, but if you eat those young little sprouts, it's even better. And it's probably the most potent natural health product or food in terms of antioxidant capacity that's really out there. The downside is that you may not like sprouts. That's a problem. And surprisingly, getting it into a pill form is not as easy as it sounds. But that's a secondary issue. That we'll deal with that some other ways. Some of the background about this came from a group that I worked with when I was back in Saskatchewan, and they gave broccoli sprouts to the spontaneously hypertensive rat, and this is an artery from that spontaneously hypertensive rat where there's a lot of inflammatory cells. And when they gave the broccoli sprouts, not only did the rats not become hypertensive, but they also had a markedly diminished inflammatory response. And so we looked at our model of bilateral uterine artery ligation at E20. It consistently provides a fetal growth-restricted animal, and it consistently shows brain damage. And this is what happens. So the animals under that perspective are small, they're fetally growth restricted. If we give the broccoli, it actually doesn't change their weight because we're permanently ligating the uterine artery. So it's not about enhancing their weight or enhancing the placental flow that's making the difference here. And their growth is fetal growth restricted throughout the course, at least up until P21. And this is what we found. It shows that, number one, their head circumference in this model is small, which is what we would expect, and it's asymmetrically small. So it's a production of asymmetrical fetal growth restriction, which certainly does predispose to developmental disability and increases the risk of cerebral palsy. So the reason we like this, or I like this, is that it's starting to mimic, I think, at least some of the circumstances under which humans are actually experiencing cerebral palsy. So we know fetal growth restriction is a risk factor for hypoxia and for cerebral palsy. We know that placental insufficiency is a risk factor, certainly. And so this is starting to mimic that a little bit more closely, possibly, than the Rice-Vanucci model. We did a bunch of behavioral tests, and basically what we found was that the model itself caused developmental disruption in all of these different aspects of developmental reflexes in the newborn rat pup. And this would be akin to sort of the early developmental reflexes that we test in humans. And when we gave broccoli, it improved about 7 of the 10 that we did here. Not all of them, but improved about 7 of the 10 to a significant effect. And we looked at a number of them, and you can see here ambulation and head lifts. They virtually are identical to each other, but the point here is that IUGR made things worse compared to the controls, but when we gave broccoli, it didn't improve things, it didn't rescue things, it prevented it from happening in the first place because we gave broccoli before the incident. We gave the broccoli during the last term, during the last trimester, and then throughout the period of suckling from the rats. So it did that in head lifts and in ambulation, in forelimb grasp and hind limb placing and cliff aversion, and in a bunch of other tests. And these are all virtually the same, but the important thing here is to realize that it really prevented the animals from getting any developmental disability compared to their controls. And that we thought was kind of a good thing. So what we did was then we looked at, early on, we looked at those Florigade stains. We looked at the death of cells, and this is the sham where there's not really that many. We looked at and this is in the thalamus again, we looked at the model itself, and you can see lots of bright green dying cells. And then in those animals, the dams that received the broccoli, we see a really virtual absence of them and back to control levels. We also did some measurement of white matter abnormalities and thickness around the anterior corpus callosum and the cingulate gyrus. And not surprisingly, in the IUGR animals, we found a deficiency or diminishment in the amount of white matter that we measured, and that returned to control levels in those animals that received the broccoli. We also looked at the inflammatory response with astrogliosis, sham not so much, broccoli, an enhancement of that brown staining that you see along the white matter areas and a thinning of that, and then, IUGR, and then the broccoli seemed to show some improvement. And then when we looked at white matter staining with a myelin basic protein stain, again the sham here, IUGR, an almost loss of white matter staining within the corpus callosum, and then a near complete prevention of that loss when the animals received broccoli. We looked at sort of our hippocampal counts as well, in CA1 and CA3, and really virtually the same thing. So we're seeing a model that produces not only white matter injury, but areas of injury within the gray matter as well that are probably responsible or could be responsible for the cognitive deficits that we see in our kids with cerebral palsy. And again, very much the same thing. This is sham, IAGR, a marked diminishment in the CA1 region of the cells, and an improvement in that using the broccoli sprouts. So I'm going to move along quite quickly here. We've looked at it with in a model of LPS as well. And here what we can see is when we give LPS to these to the dam actually on E19 and E20, and they deliver on E23, it creates again an IUGR model. But in this circumstance, when we give broccoli sprouts, it inhibits the weight loss. So under these circumstances, the broccoli sprout may actually have a beneficial effect on placental blood flow, not only as an antioxidant capacity. And similarly, when we looked at some of our neurological reflexes, the LPS group did more poorly than the controls, and that was prevented from occurring in our broccoli sprout groups. And in this group, cliff avoidance was a trend to it, but it didn't quite reach significance. Oligodendroglial cell counting was the same. In the LPS group, there was a diminishment in the number of oligodendroglial cells that were identified, and a prevention of that loss in our broccoli sprout group. So I think the point of those last number of slides is that there may well be an opportunity to look at some natural health products or foods that may well be synthesized as vitamins over time, and that can really just help the body or the fetus, who's immature at the time, ready itself for an injury that oftentimes we don't know when it occurs. So you're really putting the fetus in a state of readiness, enhancing their ability to fight inflammation and antioxidants, and hopefully prevent the injury from occurring in the first place, and making your jobs in the nursery, I would hope, a little bit better. I don't know what time it is here. Yeah, should I stop? I can say one or two. These are the last few slides. It's hard to talk about protection without talking about stem cells because they're out there. And we're being asked really a lot about whether or not children should go for stem cell therapy. And so I thought I would end by a few slides of talking about stem cells. And again, there's been a few nice reviews in the last really few months. It's a good thing this talk was in November. If it was in September, we'd have nothing to talk about. There's some really basic ways that people are doing things. They're looking at umbilical cell mesenchymal stem cells that are either being taken endogenously or from and stored, or they're looking at neuron-specific cells. Most are looking at mesenchymal umbilical cells, either human or surrogate. And they're tending to inject them either systemically or into the brain. And then, of course, they do a bunch of behavioral tests and pathologic tests and look for improvement. This is just a nice MRI scan done by Steve Ashwell in the States, along with Evan Snyder and Andy Obenhaus. And what they did early on was inject stem cells that are into the Rice-Fanucci model, just to see if they would go to the right place. So if you injure a brain and you inject mesenchymal stem cells into the brain, where do they go? Do they know for some reason to get to the right place? And in fact, and they labeled these cells so that they could detect them by MRI imaging, and these are just cartoons that they made as a result of their MR images. And what they found on the right-hand side is where the injury is in yellow. They did find that those cells labeled in red migrated to the area of injury, which was good because it suggests that there are some kind of signals being sent by the area of injury that attracts mesenchymal stem cells to that area. This is a group that also looked at the Rice-Fanucci model and I believe used mesenchymal stem cells. These are human mesenchymal stem cells, and injected them into the lateral ventricle of where the injury is. And they injected them intranasally and also intracranially, sorry. And what they found is improvement by both methods of injection in terms of behavioral outcome as well as in terms of their neuropathologic outcome. It doesn't look so much by the slides, but when they measured them, when they actually took measurements of area, they found a pretty dramatic improvement in terms of their overall pathology. And we're working with a group in Toronto actually to look at stem cell injection in our bilateral uterine artery ligation model because we think that reflects the human condition a little bit better. And these are some preclinical or studies that were done in the shiverer mouse, which is a mouse that's genetically predisposed to an absence of myelin. And they inject in several different places within the brain and the ventricles at different ages. And what we found is, these are the stem cells highlighted in bright green, is that they in fact do migrate to appropriately to the areas of myelin deficiency. So it almost highlights the corpus callosum like a highway very nicely, and they're not sort of migrating throughout the brain, but actually going to where they're supposed to go, which is in the areas of myelin deficiency along the corpus callosum. And you can test that neurophysiologically by implanting electrodes on both sides of the mouse brain and then measuring the transmission of impulses across that. And this is a slide borrowed from Michael Fellings, so don't ask me to interpret it too much because I'm not really a neurophysiologist. But basically what it shows is that we're getting impulses across that threshold, across that corpus callosum, and it suggests that the stem cells that have been injected are actually functional. In other words, they're allowing for transmission of electrical activity across that barrier. So to end with, this is what's happening right now in terms of stem cell therapy. There are several studies, approved studies, sort of in the world. The big one that I'm aware of is in Duke University, where they're looking at chronic therapy or individuals who have had chronic cerebral palsy, so severe chronic cerebral palsy, and using autologous injections. And they're currently recruiting, to my knowledge. There's several in China and Japan, I believe, that are also looking at chronic models of cerebral palsy, traumatic brain injury, and a number in spinal cord injury. And really, Duke is also starting to look at a model of, or not a model, but humans with neonatal hypoxia ischemia. This was introduced, I think, quite a number of years back. They're still not recruiting, and I'm guessing probably facing some ethical issues. And so it's unclear whether that will move forward. But this is a real phenomenon, and it's important to bring up because I think our patients are asking about it, at least certainly in Canada they are. We are not particularly advocating for it. My personal feeling is that there may be some better choices down the road, but it's certainly a real phenomenon, has gained a lot of press, and is happening in clinical trials around the world. And if you do have patients that are asking about it, if you go to clinicaltrials.gov, I think, or on the U.S. thing, they'll list all the clinical trials that have been approved. And so because you don't really want your patients wandering off to areas that are maybe not as well ethically approved. So I'm going to end there with a couple of conclusions. I think obviously perinatal brain injury is a very complex problem. There's a number of approaches that we can take to reduce the risk of injury. We know that mild hypothermia is going to work, and I'll talk about that a little bit tomorrow. But conventional approaches that interfere with normal physiologic processes have shown great promise in animal models, but there's a missing link, and I think we need to be very cautious about sort of simply adapting some of these strategies. Approaches to therapy need to include not only rescue and stem cell, but regeneration, and in my opinion, increasingly we need to start looking at prevention, obviously of prematurity to begin with, but prevention of injury in ways that are safe and efficacious for the mom and fetus. Thank you. So I think we actually have a break, unless there's some questions. Are there any questions? Oops.
I'm very impressed with the broccoli and the pomegranates. I wish I listened to my
Me
mother.
too. It's in my salad every day. I'm going to live forever.
Do you see this therapy as a preventive therapy the same way that we use folic acid? Like getting to the mothers before, some sort of therapy that started in this third trimester to prepare the mother for the delivery.
No, I mean, that is how we sort of approach the studies to begin with, because, I still feel we're not entirely clear about what's contributing to much of the injury. We're getting smarter about that. I mean, a lot of work done by Miller and others have certainly shown that infections are contributing to that. Blood pressure control is contributing to that. The things I talked about, thermoregulation and hypocarbia, et cetera, are all contributing to those injuries, but we're not always clear when they happen. And we can't really kind of use a gun to shoot all of those things down. We need to look at a way of anticipating the injury and hopefully, in my mind, preventing it from occurring, or at least providing the fetus and the very newborn premature baby with the means to fight off some of these attacks on its system. So that's how I kind of am approaching things at the present time. But we need to do it safely, and that's also the challenge. Good. Thank you. I think, is there a break? Yeah, there's a break. Okay.